So thank you for regathering in this breakout session. Again, I'm Atul Gawande. I'm from Boston, and I'm part of the team that's been working on Safe Surgery 2015, the South Carolina quality improvement effort across surgical facilities in this state. And this is our breakout session, really focusing on the challenges of implementation. There is the theory of how you can make changes that end up saving lives. And then there's the reality of being on the ground and trying to make these things happen. I had a chance to visit part of the reason I bolted out of there was a chance to go visit and meet with folks at one of our hospitals here at Palmetto Baptist. And you got to see the whole gamut of reaction and feeling around a project like this with people, nurses, surgical techs, anesthesiologists who can tell you about all the ways in which they feel that the teamwork and the sense of participation and the commitment has really changed. And then surgeons I met who have taken ownership and said, I'm using this to make better care. And then, very first person I meet walking in the door, a surgeon who I said, so what do you think about this? Well, it's probably all right. I said, well, we just showed these results that, in our first year, in the first 19 hospitals that have gotten through this, that we found a 15% reduction in mortality. I don't believe it for a minute. There's no way it makes any difference. And then we had the real conversation. How do lives get saved and how do they not? And part of what he was talking about was completely true. That there are components of the communications that for a surgeon feels like, look, how well I do this technically is an important part, is fundamentally what makes the difference here, and what happens afterwards is what makes a difference. But then I said, well, why do you think in some of these studies it's been found to make a difference? He goes, well, that's because of the incompetent surgeons. They probably need this. And then we went a little further. He said, give me an example of a death that actually was averted in South Carolina. And so I talked about the case that Chris Wright from Greenville talked about with 2 inches of air caught in the tubing and a surgical tech who said, stop, before the perfusionist pumped that air into the patient. He said, okay, well, that's one. But what we really were talking about was not data. What we were really talking about was control. And his feeling that there were forces other than he himself that were coming in to have a say in what happens in surgery. And that is still the deep part of the engagement and difficulty of being able to get everybody around the table and say we're all creating successful, safe surgery together. This was a place where I walked in the operating room and I saw people do fantastic things I'd never really seen done before. The ways in which at least 2 surgeons I watched operate not only used the checklist, but used it as a chance to tell the story of the case. This is a woman, in the one case, who has, this is a woman who came in 3 days ago and was diagnosed with a cancer of her colon and a cancer of her ovary. And now we got to figure out what to do. And everybody suddenly was there, and they knew what they were going to be there for. Our puzzle is how to get to that stage where you have more and more of all of us telling the story and turning on our minds during the operation. What I'd love to know before we bring our first group of people who are going to help us try to unravel the challenge of implementation and what it's like to make change in quality, I'd love to know a little bit about who you are. So how many of you are people in the South Carolina hospitals here? And how many of you are from outside the hospitals? And where are you coming from outside of the hospitals? AARP. Others? Quality improvement. Clemson. Excellent. Well, the second question is, how many of you are in the hospital administration and improving quality? How many of you are are clinicians? Excellent. Well, I think what we see is a smattering then of folks. I know the Clemson folks are industrial engineers. Congratulations I think you guys got an award today. And also there are the clinicians who are parts of teams, some part of administration, some not, and then the administrators who are parts of teams. How many of you are nurses here? And a lot of you were the hands that went up around administration as well. So I think that's the group of folks that will be able to try to understand your perspectives and give some feedback about what we're getting to hear. I want to introduce our first couple of folks who will come up and join us, Bill Berry and Alex Haynes, if you mind joining on stage. Bill Berry, many of you have known and seen over the years. He is the project director for our Safe Surgery program, which is really a global program. We're working in multiple countries and in many cities around, but this is the large population rollout that we're working in our laboratory for. Can we make change happen in large populations? He's a former cardiac surgeon, a former chief of surgery and chief of staff at a hospital in Northern California, was trained in the Army, and has been up and down every part of healthcare, from managed care in North Carolina to Army medicine to large academic medicine at Johns Hopkins and elsewhere, and is bringing to this now 10 years of work, having hung up his scalpel to focus on making systems change to make surgery more effective and safer, and we've learned a lot from him. And then Alex Haynes is at the other end of the spectrum of experience, right, Alex? He's in his first year as a surgical attending, as an surgical oncologist at the Mass General Hospital, but was the person who helped us when he was a research fellow while he was a surgery resident, was the first author on the paper where we first did a large-scale trial with the safe surgery checklist in that 8-city trial I briefly mentioned, and has been working ever since around the puzzles of how you implement along the way. And he's going to have a chance to talk about some of the recent data that has come out in the New England Journal that has raised these puzzles around why does implementation work sometimes and why does it not? When does the checklist work and when does it not work? So, Alex, I'll turn it over to you.
Thanks, Atul. It's a pleasure to be here today, and we thought that we would share with you we've shared with you some success stories earlier in the day, and we've published some of our success stories in the past. But we thought we'd like to talk a little bit about a story of an implementation that did not work, or at least has not been shown to work to this date. Many of you are probably aware of this study, which was published last month in New England Journal of Medicine from the province of Ontario. And I just want to talk a little bit about the experiences that our Canadian colleagues are sharing with us and the story of surgical safety checklists in Ontario and some of the lessons that we can learn from this. Just want to start off talking a little bit about exactly what this study showed and what it studied. And what this study looked at was a province-wide mandate of surgical safety checklists in the operating room that was implemented by the government, where they said you have to have a checklist in your operating room. The study itself is a retrospective study. The authors say were not particularly involved in checklist implementation. They didn't study the implementation process, but they were looking at data that surrounded the times of the checklist mandate, looking at a 3-month block before the checklist came into play and a 3-month block afterwards. They did ask the sites whether or not they were using the checklist and had fairly uniform yeses as their answers, but they had no other measures of how the checklist was used or how frequently it was used. And they collected their mortality and complications from Canadian Administrative Registry data, much as we might hear. I think the last point that I put here, again, is really, I cannot emphasize enough that there was no real measure of the quality or thoroughness of implementation of the checklist. They found that most of the hospitals reported implementation. They also found that they asked the hospitals to send them their checklist. About 2/3 of them did, and of those, only 9 had actually made any changes to checklists. They all use an off-the-shelf, either the original WHO checklist that we had developed, or a slightly modified checklist put forward by the Ontario Patient Safety Institute. Almost all hospitals reported a 99 to 100% compliance within 3 months of introduction of the checklist. So as those of you who've worked long and hard at trying to do this in your hospitals here, you know that this is not likely to represent a thorough and real change in culture and behavior. They looked at a lot of operations. They looked at about 100,000 operations in each of these 3 months. This is the whole province of Ontario. But of those operations, 60% of them were ambulatory surgery and 20% were ophthalmologic surgery. So looking at a lot of a real mix of surgery, including big and small. And what they saw was a modest decline in mortality. It's reported as being no change because the p-value is greater than 0.05, but the p-value is trending for significance, and what that represents is about an 8% decrease in complications. In the inpatient group, they saw that's where most of this decline, as you might expect, was concentrated, but they lacked the power to find statistical significance in the inpatient group. And they did not really see a change in complications, at least as measured by their clinical registry. They did see quite a bit of variation within hospitals. Each point or bar on this caterpillar graph represents one hospital. And the points that are above the zero line, they had a higher rate of mortality. This one's for mortality. The graph for morbidity looks very similar. And the ones that had a decrease in mortality are beneath the zero bar. And you can see that while there's a spread, there's probably a few more hospitals towards the right side, but we have no way of knowing which hospitals these are and whether or not these are the ones who are actually actively engaged in the project. The authors concluded, based on these findings, that mandated checklist implementation did not have a significant effect on patient outcomes in the province of Ontario, at least as measured in this brief period after. And they say that this might reflect the implementation process or lack of effect of the checklist itself. And I wanted to engender a little bit of a discussion here between the three of us about how to interpret some of these findings, because one could walk away with a lot of different messages from these data. You could walk away with the message that, well, this shows that the checklist doesn't work, and I would hate for that to be the message that someone walked away from, particularly since there have been many other studies in other environments which do show that the checklist works. The other story you might walk away with is, well, checklists don't work when they're mandated from above, and that's a possibility, but again, we don't really have a strong way to know. But I think what the lessons that we need to think about is how implementation matters and how implementation matters in achieving the effects of checklist use that we have seen when it's implemented in a more intensive research setting. And so I want to just throw open some questions. I think I'll start with Bill, and I'll say, ask Bill about, what do we know about the implementation process from this paper? How can we make some conclusions that we might be able to apply back to our work here in South Carolina and elsewhere?
Is this guy on? No. Is it on now? No. I can go up there. Okay, no, I'm on. There's a magic person in the room. There he is, all the way in the back. The implementation in this, the way that they went about it in Ontario, it's fascinating because we actually, right after the WHO checklist was made, one of the very first groups that approached us were the Canadians. And they had a Patient Safety Institute there, which since has changed names and roles, and what was there is no longer there. But the very first big project that they decided to take on was around the checklist, not unlike South Carolina and the work that we've done together down here. And we helped them. We gave them everything that we knew about how to put a checklist into place. And I think there are some lessons here. They assembled, and I still have 2 copies of it up in Ariadne Labs up in Boston, if you're ever up that way and want to see them. They're historical relics now. of the manual that they gave to every single hospital. And it's about this thick, and it's filled with glossy paper and a whole bunch of words that were supposed to help the hospitals actually implement. Now, I can tell you from looking that over myself, it would take more than 3 months just to read it, much less do all the thing that's inside of it. And I think what happened was that the book went and sat on a shelf somewhere, if it ever came out of the envelope at all, and that the hospitals worked really hard, just like a lot of American hospitals worked really hard when the Joint Commission mandate came around, to create documentation that absolutely showed ironclad, if an inspector showed up, that everyone was having the benefit of the universal protocol, or the timeout as we usually call it. I think that was the kind of implementation that ended up happening in Canada, that it was focused very much on documentation and very little on action, and that's my takeaway. I think one of the things that's really, really important when we're trying to decide whether something like this works or not, is that we have to make sure that it is being used. Because if you don't use it, it can't work. And my reading of their work is that it wasn't. The odds of it not being used is exceptionally high, because they looked no further than asking people what they were doing.
Thanks, Bill. And Atul, this morning you talked a little bit about some of the sort of time it takes for change and how hard it is. What do you think about the time frame studied in this paper in relationship to some of those thoughts, and how might we be able to understand more about what went on in Ontario?
Yeah, I think the fascinating thing is, how long does it take to create change? People looked at the initial study that we all did together, and we worked with 8 individual hospitals, and then implemented in a fairly short time period, in a matter of a month to 2 months in those hospitals. But we picked them for their willingness to engage and drive it through. When you try to change, in their case, nearly 100 hospitals, although in 3 months it's the law, so when you ask, are you obeying the law, everybody raises their hand and says yes. The ability to make change happens more gradually. I explained what the Veterans Administration's success rate was. They trained across 74 hospitals, had everybody stop the OR and train as teams for a full day, before then rolling it out in each hospital, hospital by hospital. And it took 3 months after that before you even began to see a dip in the outcomes. What they found by the end of the next quarter was about this size reduction in death. But then the quarter after that, there was another dip in reduction of death, and then another, until they had reduced their death rate 18%. And we seem to see that over and over. Scotland is another population of folks who's worked with IHI around a collaborative to implement the surgical checklist. And it took them more than 2 years. Very similar pathway to what we've experienced here. And they have been able to reduce the deaths by substantial amounts, so that by 3 years, they are now achieving some of the lowest death rates for populations in the world. And so I think our takeaway here, and Lizzie's giving us the sign that we want to make sure to transition to bringing a larger panel up on board, is I'm interested in hearing a little bit from you. How many of you are working on projects to implement the Safe Surgery Checklist? If we can see hands here. And how many of you are hearing someone push back and say, I saw this study and it shows it doesn't work, we're wasting our time? So that's a large number of folks. So really important that you're able to hear what were some of the concerns of the study. And I'd say there are 3 main messages. Number 1 is that this is one of many studies that have studied implementation. The Veterans Administration implemented successfully with team training and reduced their death rate 18% over a year. Scotland has reduced their death rates even further with a long 3-year process. And in Canada, they've only looked at the results at 3 months, found a 9% decrease, and said it wasn't good enough. And we know we have to watch for longer, and that's what we're doing here.
Thank you. That's an excellent insight from both of you. So, I think I'll turn the podium back to Atul now, and he's going to invite up a number of people who've been involved in the implementation efforts here to talk a little bit about the process and some of our learnings over the last several years.
So if our panel can join us on board here. Thank you. And if we don't mind passing the microphone around, is the microphone turned on? Yes, excellent. If you could all just start, I'm going to ask you all to each introduce yourselves, and I would love to hear from you. What has been the most successful or beneficial thing that you felt you've seen in the process of being part of implementation? What do you feel has changed? And also, what do you feel hasn't changed and is a challenge? And just name one challenge as you come down to introduce yourselves, if you don't mind.
Can everybody hear me? Yeah, okay. So my name's Beth Morgan. I'm a nurse and the staff educator for surgery at Palmetto Health Baptist here in Columbia. We jumped on this initiative back in 2011 and have had our share of ups and downs along the way. But the biggest thing that's sort of come out of this, I really think the sort of core principle that we've kept along the way has been empowering the staff to feel like their voice is heard in the OR, that what they say matters, that they're a part of the team, and so that carries over to so many different aspects of the work that we do. But that's kind of been the biggest, I would say, success that we've had through this project. You know, challenges, there's been many, but you know, just engagement in general is challenging, and I wouldn't say specifically for surgeons. I would say for staff members as well. I think for everybody, it's just difficult, and you're going to have the, you know, the up and down. But you know, the best part for us has been at the beginning when we started with you guys. The first part of it would be we're working great, everyone's on board, and then we'd start to slip a little bit and go back to what's comfortable, and it would sort of take us a while to catch it before. Now we can tell when we're slipping a little bit, and we can get back on track. But it's so easy to go back to what's comfortable. But I think we've got a plan ready for that.
Excellent. Chris, introduce yourself.
Yeah, my name is Chris Wright. I'm a cardiac surgeon, thoracic surgeon in Greenville Health System. I also serve as Chief of Medical Staff Affairs. And I think what I've seen, a big benefit from this is everyone talks about the checklist itself, but what I've seen is actually a better attitude towards performance improvement in general. I think this project just as a whole has introduced to the staff in the OR and some of the other places in the hospital that performance improvement is important, and methods to try and make things safer and better, improve quality, are important. And I think outside of what it really, all the other things we're talking about that the checklist actually has done, I think what it has done is improved our culture of we need to improve, we need to improve. And I think the biggest challenge we're facing right now is the drift. You know, I want it to become routine, but not routine. I don't want people to start to forget about it, for it to become not as important. I think that's our biggest challenge right now, to keep the momentum, to keep the power.
Two themes that come out of those introductions. One is that we're a long way from the description of the implementation challenges of a couple years ago, when it was getting initial traction to make any change whatsoever. That the inertia that sets in is drift, we've got it in place, but it can become a mindless tick box, not something that is simply not accepted at all. And both of you are describing a process where it's there, but are we using it for its full power?
I'm David Oliver. I'm a cardiac anesthesiologist at Richland, and I work in the patient safety and risk management office once in a while for Palmetto Health. It's been nice to see it work. One of the things that I think was really impressive was that when I started doing this in a very small way at Richland, I started with the pediatric surgeons because I needed a project for another reason. And I took on the two subspecialists in pediatric surgery that everybody said I should stay away from because they were going to be the hardest, and they really were very simple to get to buy in, which was a surprise. I think the problem now is that there's a lack of respect for the checklist and what it can do, and that everybody's back to leaving music on or talking over it, or somebody says, oh, we got to do this, and it's done by form and not by intent. And keeping that fresh for everybody can help. The idea that you mentioned of telling the patient's story, which is being lost as we move into electronic records at the start of the procedure, is a really good one that I'm going to try to carry on.
Thank you. My name is Ashley K. Childers. I'm a research assistant professor in the Department of Industrial Engineering at Clemson University, but more than half of my time is with the Quality and Patient Safety team here at the South Carolina Hospital Association. And for the last 3 years, I've been traveling around to visit you all, and I've spent a lot of time in your operating rooms in the past couple of years learning about how you're using the surgical safety checklist. And for me, the most successful thing and the challenge is the same thing. I've gotten to go to maybe 70-ish site visits. I've seen this checklist used in hundreds of cases, hundreds of times, and I've seen the variability that comes with it. I've seen people that push back, but I've seen people that are doing this and they're doing it well. And I've seen people who say, this checklist has helped to improve our culture. This checklist has helped to improve our teamwork. This checklist helped me to catch something that could have harmed my patient. This checklist helped me prevent a wrong site surgery. This checklist saved my patient's life. But not everybody's heard that yet. And so I know how good it can be because I've had the pleasure of getting to see it. And so then my greatest challenge is how to translate that to other people and make other people be a believer in how good it can be. Yesterday at the American College of Surgeons meeting, we talked about this, and if people aren't to a spot yet where they feel like it's helping their teamwork and they feel like it's helping their patients, then I think we need to look for tweaks to try to find that spirit of the checklist and do it in a joyful way, that because I know it works and I've seen it. So for me, that's the challenge, to get people to see what others have seen.
Ashley, if I could follow up with a question for you. You're an industrial engineer
Yes, sir.
coming into our world. What is an industrial engineer?
I'd be delighted to tell you what an industrial engineer is. Oh, thank you. That's an easy one. So industrial engineers are the people who care about systems. We want to make things better, faster, cheaper, safer. We care about maximizing and minimizing things. We care about human factors. We care about ergonomics. We care about all those. To me, the best way to think about it is how people and machinery and information and materials and environment and equipment all flow together and work together in a system, and we have to think about constraints and all those kinds of things. Did I do good, students? Thank you. So that's what we do.
Excellent. Well, part of the fascinating learning process for us is learning about implementation from someone who comes from that perspective and comes into our world and says, there's lots of things you could do a little bit better here, and is able to report back and give us external eyes and ears on what we ourselves do. And I just think it's been an amazing thing that you all have opened your operating rooms to let us see in through her eyes and have that kind of glimpse. I'd love to now, I'm going to open it up to the group, but love to hear from each of you to talk about what's the most innovative idea that you've seen related to how the checklist can be used to accomplish the kinds of goals that Ashley has talked about, and you've gotten to be in the operating rooms yourself, Ashley. So what's just one, what's the most innovative idea where people have been able to use it to improve care, improve the patient's experience, and potentially their outcomes?
Well, I can talk about the checklist, and not this checklist in particular, but we had a problem in the intensive care units where the patient's drips were not being continued from the OR, ventilator times were increased, information wasn't being communicated. And the nurses in the ICU came to me and said, because I'm the checklist guy, they said, this checklist thing that you do, is there any way we can do one between the nurse anesthetists and the ICU nurses so there's a better handoff? And we got together and developed, I told them about, it's a communication tool, 10 or 15 things they need, they want information, they want it communicated, and we did. And I think that was a pretty innovative thing that they did. And I was also pleased that people around the hospital are starting to see that this is a good idea. And we have some projects going on with discharge planning, and we're moving into the cath labs and the GI labs. So I think we're trying to innovate with the checklist to move it out into other places throughout the hospital.
It's been a fascinating process. You know, we took the idea from aviation and spread it into our world. It turned up particularly in the central line checklist in ICUs around being able to make a few basic things happen to protect patients in that one procedure. We then expanded it to all these procedures in operating rooms, and we're seeing exactly that. It's moving into people using that approach and designing it themselves for the handoff in the recovery room or the ICU, or going even farther and bringing it into cath labs and elsewhere around hospitals. Are any of you beginning to see that happen, that sense of spread, that you're seeing it applied and the ideas begin to go elsewhere? Some nodding heads, maybe. Another innovation.
So one of the things that we started out with, we had the posters on the wall, and it worked great. But one of the things that we found helpful was we have our chart, and we're constantly using reference text in there, skip guidelines, antibiotic doses, things like that. And so it only made sense for us to have a smaller version of the checklist in the chart for a reference. And then it sort of turned into, hey, we can actually put this next to the consent form. And so the way we do it in our operating room, the checklist is actually right above the consent. And so that gives the nurse a sort of way to, for lack of a better word, thrust it at the surgeon and say, here you go, we're ready. And that's been super effective for us. It's also nice from a coaching standpoint, as I'm in there having these conversations with surgeons and teaching them about the checklist, I sort of hold the chart here and I can point to each thing as they're going through it. And when we started doing that, it really changed the people that are more engaged in the operating room now. I mean, it really did change a lot.
Any suggestions from you, Dave?
No. But one of the challenges, as I was listening to Beth, is going to be how to do this with a purely electronic record. When you have a small screen or two, how are we going to get everybody to see all the things that are there quickly? Because surgeons are all about not wasting my time, right?
Yes, we actually have the checklist in electronic form, and all our operating rooms have monitors because a lot of procedures now are done laparoscopically or with video, so we can project the checklist on a screen, and hopefully that'll help.
So Palmetto Health just opened up a new hospital, and it's going to be, paperless. And so one of the things that they're starting with immediately there is they're going to have it the same way on a screen. And so they've actually started that as they've started to see patients, and they use it on the monitors, and it's worked really well, the electronic consent with the checklist on the monitor. So.
Ashley, anything that you've seen as an innovation?
Sure. I talk a lot about your hospitals, the three of your hospitals often, in innovative ways that we display the checklist. One of the things that we think is important is that the checklist should be displayed. It's not something we should be doing from memory. And each of you, you guys work in hospitals where it's in the chart and on the wall, where it's displayed in monitors. And then there's a couple of other hospitals who have posted this on either a whiteboard, or they've made a poster and they've put a piece of plastic over it. And one of my favorites is where the circulator stands there at a board. It's huge. It's got a piece of plastic over it. It only cost them $6 to cover that. And she stands there. And the thing I like about them, not only are they talking about every point for every patient, everybody has a voice. And so it says, the circulator says, and there's 6 points there. And the scrub tech says, anesthesia provider says, and surgeon says. And the circulator stands there and she or he checks off everything they hear. And then if they don't hear one of those things, there's not a check there. And so then they go through and discuss it. So to me, the innovation has been in ways to display the checklist, whether it be on your monitors, whether it be in your chart, whether it be on your walls with the posters you guys made at Palmetto Health.
Well, Bill Berry is to come up and have a few things to say by way of wrap-up, but I'd actually love to get a little perspective from a couple of you. Maybe there might be one or two questions that you might want to put to the panelists. And if you have a question, raise your hand. I'll bring you the microphone. And maybe we can get everybody doesn't have to answer, maybe one or two to offer some answers to the questions that you might have, if that's all right, Bill, to grab a little. All right, but well, so there'll be one question back. I'm going to come back there with the mic. Here you go.
Handing the checklist to the patient so that the patient knows that you are using this checklist. Does the patient know the checklist is present?
So the patient use, does it work to have them be part of it?
One of the things that we're still struggling to get done, because you run into the sign committee or signage committee, which sounds like something on a farm, is to put the first column of the checklist in the patient's room and outpatient, so that the nurse anesthetist or anesthesiologist, or both ideally, and the circulating nurse and the surgeon, if available, will stand there with the patient and their family and say, all right, this is what we're doing to make sure we're getting everything right, and run through it.
Yeah, so one of the things we ran into, so we were all super excited about this project, and I thought, I want everyone to know that our hospital uses the checklist. And so we went to our marketing department and we're like, what can we do to let the public know that Palmetto Health uses the checklist? And so we were immediately met with, do you guys use it every single case? And we were like, well, we do it most of the time. And they said, you know, until you're 100%, you really don't want to sort of put yourself out there. But it was funny, so as we work with a lot of different people on our teams, we have some business folks that aren't medical minded. And so as we've gone through this process, a couple of the girls have said, you mean you don't do that already? And so it's a little scary for people that don't realize we don't have a checklist already in place. And so I think from a sending it out to the public thing, it needs a little direction.
Yep.
Really quickly, let me tell you, from now visiting about 50 different places, there are a handful of people that are that maybe have a laminated copy or something in their pre-admission testing appointments, and they're talking with folks about, you may see this tomorrow, this is what we do, it's for your safety, you're going to be asked a lot of the same questions, you may hear some questions about these types of things, and so people are promoting it as something they use in their hospitals. I even heard somebody the other day say, what if we put it in the chart and like we all could sign it at the end of the case and like give it to the patient, say, we use this actual sheet of paper to talk about your care today. So we talked about getting the patients involved in this project a long time ago, but we wanted to be sure our hospitals had enough time, like you said, to get to a point where we're confident to say we are a checklist hospital before we start telling our patients that we are a checklist hospital.
Another question or insight. Let's go over here. If you mind explaining who you are too.
I'm Elizabeth Mack. I'm a pediatric intensivist, and Ashley has actually helped me a bit with this particular issue. So we also run a sedation unit in our children's hospital, and we're actually in the process of kind of going through the IRB to look at family satisfaction, provider satisfaction with the checklist, that kind of thing. But when we put kids to sleep, the families are there, and I would say that 99% of the catches with the checklists are actually the family catching. So we'll go through it.
Can you give an example?
Yeah. So we have a little girl. She's not little anymore, but when she was diagnosed with leukemia, she was 12. Now she's about finished with her treatment at 15. But this has come up multiple times. So she has AML, and we know she has AML, and we think of her as a hemonc patient, and she's there for either her bone marrow or her lumbar puncture with intrathecal chemo. And repeatedly we say, no diabetes, and she says, I have diabetes. Don't forget I had pegasparaginase reaction, and I had pancreatitis, and my pancreas is dead. So you think of me as a leukemic, but I'm also a diabetic. And her mom, actually, before she was sort of brave enough to speak up, her mom would catch us. And so now it's sort of a joke with her checklist that, she's like, I have diabetes before we even say her name. But I think that most of the, when we go through the MPO or we go through the procedure, I don't know what the surgeon wanted. I mean, the mom knows what it really is. I mean, we can compare the order, but oftentimes maybe the order is wrong or whatever. So before the checklist, we had imaged the wrong leg a few times, an MRI, which we weren't cutting off any legs, but that's another sedation, that's another a whole risk of anesthesia, all that sort of stuff. So I think it's a little different in our world because we're not pre-medicating anybody, and so they're not loopy yet. But maybe I think that most of our catches, maybe because we're not cutting anything, that it's different in our world. But most of our catches are family and patient catches.
If the Cheesecake Factory worries about sending the wrong meal out to the customers, I think we'll care about putting a kid to sleep and imaging the wrong leg. There were a couple hands over here, I think I saw.
At Palmetto, Richland, the teaching facility, I know that you've implemented in some of the services. How do you incorporate the residents training so that we're training the future leaders?
As I bring the microphone up, I'll just mention that this was an innovation I learned from a surgeon here who told, that changed my own practice, which was that they would have the resident or the PA in the case run the checklist themselves. And it was partly out of a teaching effort for them to understand, what does leadership mean? You have to explain to people the story of why we're doing this case. You have to get everybody's attention, and if they're not paying attention, or I find the hardest thing for the resident, just to speak up and be heard. Use your voice. Speak up, make sure people understand. And it literally takes a couple of years until they get to the point that they have the confidence to speak up. And invariably, when you ask them, also tell them how long the case will take, how much blood loss there will be, and what the reasons for the operation are. Half the time, they don't really know. And it becomes part of the teaching all along the way itself. But I'm curious about others and what they're finding or doing with residents, whether it's anesthesia, surgery, nursing students.
This would be another opportunity for growth, of course. Many of the general surgeons are having the residents do the checklist and cover that part of it. In other specialties, not so much. They're aware of it. They know that it has to go on. They see it modeled for better or worse. The students get to see what's going on. They may go to other facilities and see it done better or worse, at least differently, all of which can be valuable. So hopefully, since they're in a student role, they're going to pick up the best practice and carry that forward, and we'll continually make the ship ride a little higher in the water.
One of the things I'll just add on that we had validated for us yesterday when we had an airline pilot come to visit was that in aviation, although the checklist came in a long time ago, it was even in the mid-1980s, captains on airplanes routinely said, I don't do the checklist. And there were 747s that were going down from missed steps along the way. It didn't change until they made it part of training, and you simply couldn't get in the cockpit until you'd been trained and understood how to work your way through making teamwork work. And he called it, the emotional intelligence part of being an effective pilot. And for many of us on our teams, I think it's the emotional intelligence of the residents and the nursing students to understand how to project your own leadership in an operating room and beyond, right on out into the hospital and all across the board. Were you going to add anything, Chris? No, I'll bring it around. I see another hand here. Let's get Helen here.
Well, I have a comment and a question.
If you can explain who you are for other folks too.
I'm Helen Haskell from Mothers Against Medical Errors, so I'm a patient advocate, consumer advocate. And I have a comment and a question, the comment being about the patient involvement. I think that it's true all the way through, which is why people advocate for things like bedside rounding and bedside change of shift, that it is the patient who's far and away the most likely person to catch mistakes. So if you want to catch mistakes, you really have to have the patient involved. And then the question is, when you're talking about reducing mortality, what sort of inroads are you trying to make in post-operative care where so much surgical mortality occurs?
Well, this is almost, let me try taking this one, which is, I've got two microphones. I can just use one. Okay. This is almost, checklist 2.0 and beyond. So one of our projects was one in which we looked at, communication failures have this pinch point in the operating room, but the basic failures are a failure to get information into the surgical team and then failure to get information out from the surgical team going onward. And those loops of communication are breakdowns that that we were looking at malpractice cases where there was huge damage, either death or major organ injury. And in those cases, what was frequently happening was a breakdown in communications after the operating room, where there would be trouble brewing and the surgeon would not be notified. The information wouldn't be getting to the surgeon. We found that in 2/3 of cases, looking at all of our hospitals at Harvard, that the surgeon was not being notified when the patient was being transfused in the night, had turned up in the emergency room, got transferred to a step-down unit or an ICU, went into AFib, we had 15 major events that happened, and it was 2/3 of the time that they weren't notified. We then instituted a policy and found it took another year of effort to drive the policy, but the policy was that for these 15 things, that the surgeon would be notified within 60 minutes. And number 16 on the list, which has been the most powerful, was that if the patient or a family member insists on speaking to the surgeon, that they are immediately contacted. And that completely changed the perspective from seeing yourself as the wall to seeing yourself as a part of making sure that communications happen. The third kind of hurdle, which is the interesting distance to go, is we're now testing doing 360 reviews of surgeons in all of our hospitals, and we've done more than 400 now 360 reviews with perspectives that incorporate findings from their patient surveys, along with what referring physicians, nursing staff, fellow surgeons, supervising people, front desk people have to say. The average surgeon had a review from 22 people. The major output besides numeric stuff was 2 things that the surgeon should stop doing, 2 things the surgeon should start doing, 2 things that the surgeon should keep doing. That's now expanded in a couple of our hospitals to all staff, not just surgery attendings, but also the surgical staff, nurses, and others themselves. And that is, all the industrial engineers here, these are all normal things in other industries. But for us, we're bringing these 1970s concepts in for the first time, and they very much govern communications that extends not only to the recovery, but how well does information pass back and forth, and how well do we do all along the way with our referral physicians, with bringing issues in. And we're finding real challenges. I mean, 20% or so of the physicians who are not getting what we call red zone levels for being able to either have communication or competence and judgment issues that have to be dealt with. So that might be a sign of what could come down the line as we get more ambitious about what we try to do. There are a couple more hands up, and Bill, should I continue with? Yeah, keep going. And then I'm going to let you wrap up with the last 5 minutes then, instead of 15.
Hi, I'm Pat Turner from Community Health Systems, and we're getting to roll out our checklist. I'm planning to do that mid-April to 206 hospitals. And we're rolling it out to all parts of our hospitals that do invasive procedures. So it'll be the C-suite, it will be the cath lab. And what I'm finding as our major challenge is how to bring people from a very rigid checklist where all the boxes had to be checked to a conversation around the patient and the procedure. And I'm just want to know, is there any advice for how to get beyond that or how to make that move?
You guys have lived this.
I think, one way I started looking at it, and our team, we talk about implementation. What it really is marketing. So you have to get people to do things that you want them to do like that, and to get that attitude change, you have to do 2 things. One, you have to get them to believe they need it, and 2, you have to then show it'll be beneficial to them, and it's not going to take their time, and it's something that they really need to do. So I would have you look at the system and find out what you can do to make people, your staff, believe you need this. You need to do this, and this is something that's going to be good for you, and it's not going to take too much time. It's going to actually be beneficial to you, and it's going to make your life even better. So rather than looking at implementation, trying to push it down their throat, think of it as marketing, like you're trying to sell it to them almost.
What other advice? If you could give her one piece of advice, I'm going to go down the line here. We'll make this the last thing we try to do. If you could give her one piece of advice for how to make sure it's not a tick box, but it's a tool for improving team communications, what would you give her?
So if I could wave my magic wand and start from the very beginning again, I would put the time and effort in on the front end before the first poster even hits the wall. I would have those one-on-one conversations if it means going to that physician's practice and saying, this is our idea, tell me what you think would best, how can it help you in the operating room? And then that way it becomes theirs. And I think you're going to get away from that checkbox if they feel ownership as sort of, creating that. But good luck.
I think another thing you can do is break it down and give each person in the team that's involved a little piece of those. So they're not checks. It becomes theirs and something they're doing. So it's not one person going down and checking. It's that individual all of a sudden has 4 tasks that they have to participate in and make it relevant to what their position is. And part of it, they can announce who they are, what they do, and this is my job, this is my role. So now it's not a tick box, it's what they do, and they're getting to tell about themselves.
Rather than a list of tick boxes, as we call it, think of it as each person giving a paragraph in that patient's story, so that with all of them talking and speaking up, everybody in the room knows something about what's going on for that person, which is why you're all there to start with, paychecks notwithstanding.
I'm lucky I get to back cleanup here, because I stressed a little about you saying choose one thing, but you guys said the things that I'd have said, and I asked people on the road, if you had to start this project over again, what would you do? And they say if I had to wave a magic wand, one of the things I hear often is I wouldn't have educated in silos. So I wouldn't have just taught the nursing staff and just taught the scrub techs and the anesthesia providers and the surgeons. And so if you can get folks together for these conversations, get them doing demonstrations of it, working together to learn about what they're doing, I think that's what a lot of people haven't had success in that, but they look back and say, man, I really wish we'd have done that.
I'll just echo that point and give Bill a chance to come on up on stage to help close this out for us. Bill and I have been working on spreading this globally, and you can imagine in low-income places where you don't have a lot of resources, this is a very, very difficult thing to pull off. And one of the groups which Bill has worked with is a group called Mercy Ships, which brings a ship into poor places, Philippines, Sub-Saharan Africa, moors it off the coast, brings patients on to have surgery, but also brings teams on board to use their facility to do operations they otherwise wouldn't have done in their place. And Bill asked them in their last set of ports to try changing the way they did their implementation of the surgery checklist and taught people about it. And then they were going back to see if in those institutions they introduced it and made it stick. And what they found, in one group, they trained just the anesthesiologists. In the other group, they trained just the surgeons. And in the third group, they had trained surgeons, anesthesiologists, nurses together as a group. The only group in which it stuck when they came back more than 6 months later were the ones when everybody had been trained together and heard it and were in the same room when it was happening. And I thought that was a fascinating result. Bill, if you mind batting cleanup for us and helping us close this
you're
out.
giving me the hardest thing to do of all, since I had 20 minutes to talk to you and now I have 7.
Yes.
Which is really tough. So I'm not going to give you all a seizure by blowing through a bunch of slides that you wouldn't be able to read anyway, but kind of summarize for you what we've found since we've been working down here. What Atul showed during his keynote about the mortality data, I think is suggestive. But in that data, and when we think about it, and it's very, very important, I don't want to lose sight of any patient that gets injured in the care that we provide that's preventable. 1 is too many. It doesn't take 15% of anything. 1 patient is 1 too many. and I want us all to be able to get to the point, and I said this yesterday for those of you who were with me, when we took off from Boston yesterday morning, the first officer introduced himself, and he also introduced the captain, which I thought was really cool. Kind of, we don't do that in the OR. Well, maybe some of us do, and maybe some of us do it more now. But he introduced himself and his captain, and the very last thing, what he closed with was, we're going to get you to Charlotte, we're going to get you there on time, and we're going to get you there safe. And I had surgery last fall on my foot, and I wish the last thing they had said before I could remember anything afterwards, since they must have given me a bunch of sedation and I don't remember anything at all, was, Bill, we're going to keep you safe. And I think that's a promise we need to make to our patients, and then we need to dedicate ourselves to keeping it. And that's what this is really all about. It isn't about big numbers and that kind of thing. This is about affecting individual patients that come in front of us every single day. And that's what's really important. What I was going to talk to you about and show you a bunch of statistics and graphs from all of you who have participated in this was the culture data that we have collected as we've done this project together with you over the last 3 years. Over that time, we've collected more than 2,000 surveys from the operating rooms of over 30 hospitals. That's more than half the hospitals in the state that represent about 75% of the patients that are operated on in the state of South Carolina. That's a lot. And so it's a lot of data. And there's a really powerful message in there. The first one is there's some problems. There's a disconnect about leadership, where the surgeons, and we talked a little bit about this yesterday when we had some surgeons in the room, where the surgeons think that everything is fine around their own leadership, and the anesthesiologists kind of feel that way, though not as strongly. But the rest of the folks in the operating room don't quite agree. The nurses and the technicians, they think that the leadership that's manifest by the surgeons they work with every day could actually be improved. There's a gap. And there's a clear gap that I could show you in like slide 25. But the cool thing is, in the hospitals that have been working on this, the gap is closing. Now, an interesting thing has actually happened over the course of the project. The surgeons actually think they're better leaders. Well, that's kind of cool. Maybe they are, the ones that actually use the checklist. But the people who are around them are more than compensating for what would increase the gap, with the surgeons now feeling even better about their leadership. They think that the surgeons have come even farther than that. So that gap is actually shrinking. But there's one other really cool thing in here, and we are able to ask people about what they feel about the teamwork in their operating rooms, not by watching them like Ashley actually can do for us, where she can come out and say the teamwork was pretty good or it wasn't so good. But we asked them, the nurses and the physicians that are working and the technicians that are working in the operating rooms, how do they feel about the teamwork? And what's interesting is what goes along with that. The same people who feel that the teamwork is pretty good in their operating rooms are the ones that are most likely to say that they would have an operation in their own hospital. Maybe that's not so surprising. They're also the ones that feel like the level of respect in the operating room is high. And I think that's absolutely fascinating. And then when you ask them about their ability to communicate and speak up, they also are the ones that say, just like I know happened in your operating room, Chris, that they feel like they can speak up. So what is really interesting to me is all those things come together in a package, and they've all been getting better across the whole state and the hospitals that work with us. Now, I want to make an appeal to anybody who has a hospital where they haven't done this survey, that they can help us in a big way, and for a selfish reason, and that is you can help teach us even more by giving the survey in your own hospital. You can learn about your own hospital through the survey, because we'll be happy to give you feedback. That's part of what we do. But we also want to learn from you. And where it's really cool is where you can do a survey before, do the work, and do the survey afterwards. So all of you at CHS, if you want to put that in your brain, you could help us tremendously by thinking about if you could do something like that, because I think that's part of the story we want to be able to tell when we go out. Not only are people communicating better, but they feel better about the place where they work. They're more confident to speak up. They feel like they're respected. I think all of us know, particularly the nurses out there, I don't know if there are any technicians, but if you live in an environment where work in an environment where you feel respected, you're probably less likely to leave it. And if you're working in an environment where you feel like you're not appreciated and respected, it probably doesn't take a whole bunch for the hospital down the road to pull you away with an extra $5 an hour. So I think all these things become more and more important in what we're doing today. Anyway, that's what I was going to tell you. That's at a very high level, and I didn't show you the p-values and all that. What we're seeing, though, across the entire state is improvement, and that is absolutely incredible. It means there's real work going on, and your staffs in many places actually know that it's getting better, and that's a wonderful thing. So I think we're close to the end of our time together. I want to thank you all for being part of our breakout session this afternoon and for participating with us. Please keep doing what you're doing. Your patients appreciate it, having been a patient not very long ago. I certainly appreciated it when the team that was taking care of me ran their checklist, even though I was too sedated to know it. So, thank you all.
Thank you.